Developmental dysplasia of the hip. Developmental dysplasia of the hip is a disorder of abnormal development resulting in dysplasia, subluxation, and possible dislocation of the hip secondary to capsular laxity and mechanical factors. Epidemiology. Most common orthopedic disorder in newborns. Dysplasia is seen in 1 in 100 by birth. Dislocation is seen in 1 in 1000 births. More common in females, 6:1. Most common in left hip, probably due to the most common intrauterine position being left occipital anterior. Bilateral in 20%. Firstborn, female, breech family history, oligohydramnios are the risk factors for the congenital dislocation of hip. Clinical presentation. Children less than 3 months will present with a palpable hip subluxation or dislocation on examination. Barlow test will be positive. Artoloni test will be positive. Gallagher test will be positive. More than 3 months to 1 year, limitation in hip abduction and leg length disparity will be seen. More than 1 year, that is walking child, will present with a pelvic obliquity, lumbar lordosis, Trendelenburg gait, and toe walking. Coming to the investigations, ultrasound is the primary imaging modality from birth to 4 months. X-ray becomes a primary imaging modality after 4 months, after the femoral head begins to ossify. In the X-ray, you have to see Hillgrener's line, Perkins line, Sentinel's line, acetabular index, center edge angle. MRI is increasingly used to evaluate the reduction of the hip after closed reduction and spica casting, but it is not a routine investigation. Chronic dislocation leads to development of secondary barriers to reduction. The fulvinar thickens, ligamentum teres thickens and elongates, transverse acetabular ligament hypertrophies, hip capsule and iliopsoas form a hourglass configuration. Then anatomical changes also develop. Increased femoral anteversion is seen, flattening of the femoral head, increased acetabular anteversion, increased obliquity and decreased concavity of the acetabular root is seen, thickening of the medial acetabular wall. Less than 6 months old and a reducible hip, Paulic harness is enough, but it requires a normal muscle function for successful outcomes. 6 to 18 months old, close reduction and spica casting. More than 18 months old, failure of the close reduction, in such cases open reduction and spica casting is required. More than 2 to 4 years old with a residual hip dysplasia, open reduction and femoral osteotomy. More than 4-year-old, open reduction and pelvic osteotomy is required. Management of developmental dysplasia of the hip during childhood requires a knowledge of screening and imaging as well as safe and effective treatment and long-term follow-up. Etiology of the DDH is multifactorial, but a recent RAST study suggests that early swaddling produces recalcitrant acetabular dysplasia and deformity of the triradiate cartilage. To screen or not to screen for DDH. According to a recent decision analysis, the optimum screening practice for DDH is universal physical examination plus selective ultrasound for those infants with an abnormal physical examination or risk factors such as breech delivery or a family history of dysplasia. This strategy results in the lowest rate of hip arthritis during childhood. I think this should be done the pediatrician during immunization follow-up. Initial treatment. The Paulic harness remains the most appropriate initial treatment for DDH. Sonographic positioning of the femoral head below the labrum when the patient is initially fitted in the harness is a predictive of success. The successful harness treatment produces an alpha angle of more than 60 degrees and the femoral head coverage greater than 50%. Hips that fail to reduce by 2 to 4 weeks in a Paulic harness may be treated successfully in many cases by an ill-filled brace, reserving close reduction and spica casting for those who don't further respond. Prolonged harness treatment is often successful and does not result in an increased alpha angle. Femoral nerve palsy in Paulic harness treatment. Paulic treatment may produce a femoral nerve palsy due to hyperflexion of the hip. The risk is higher in older infants and in those with a higher degrees of dysplasia. The nerve palsy always resolves over time, but it is an indicator of hip that may need closed or open reduction. Femoral nerve palsy was more likely in older, larger patients in whom the developmental dysplasia of the hip was higher severity. Patients whose femoral nerve palsy resolved within 3 days had 70% chance of having a successful treatment with a Paulic harness, whereas those who had not recovered by 10 days had a 70% chance of having treatment failure with the harness treatment. The effect of femoral head ossific nucleus in the treatment of DDH. For hips requiring closed or open reduction, waiting until development of the ossific nucleus does not lower the rate of avascular necrosis. No point in waiting. Start the treatment as early as possible. Open reduction and osteotomy. Open reduction is most commonly reserved for hips failing closed reduction or for children older than 18 months, although there is some variability on this point. Also, for patients older than 18 months, osteotomy is usually performed to ensure adequate bony remodeling. Iliac osteotomy has been shown to improve hip morphology more reliably than femoral osteotomy. A combined procedure for high dislocations in patients with a DDH. A combined procedure including open reduction, femoral shortening osteotomy, and an acetabular procedure is often necessary to obtain a desirable result in a children of walking age who have a high reading hip dislocation. Pemberton osteotomy. The Pemberton osteotomy may produce type 2 avascular necrosis if it causes pronounced inferior displacement of the femoral head, later resulting in valgus deformity. The study published in JBD's 2010 showed significant correlation between excessive reduction of the femoral head and development of AVN. They postulated that the lateral epiphyseal branch of the medial circumflex artery was vulnerable to compression with an increased inferior displacement of femoral head. Results of open reduction and Salter osteotomy show that 54% of patients maintain their native hip joint at 45-year follow-up.